Health Watch is presented by UMass Memorial Healthcare. Here, caring for you.
Welcome to Health Watch, presented by UMass Memorial Healthcare. I'm Brittany Schaefer. Today's topic is melanoma and how it's more than just a skin cancer.
Melanoma is typically what we consider a skin cancer, much like other skin cancers, squamous cell, basal cell carcinomas. But the difference is melanoma's tumor biology is a bit more aggressive. It, unlike the others, has much more of an ability to spread to other areas like lymph nodes and to distant organs. And so when we think of melanoma, its treatment, whether it's resection, it's checking the lymph nodes, its additional therapies, typically are a bit more aggressive than what we more typically face in the other skin cancers. One of the big things with melanoma is its ability to spread not only through the skin, but also to the lymph nodes or to spread distantly to other organs. And so it's really key at diagnosis to understand the stage of the cancer, because that helps guide our next set of decision making.
What types of outpatient surgery are available for treating melanoma?
Typically, most patients come in and they have a biopsy of some form, whether a punch biopsy or shave biopsy, typically with their primary care doctor or dermatologist. This will give us the characteristics of the melanoma to help guide the next steps in treatment. At that point, our next step is to determine the traits of the melanoma. We want to know things like its depth, we call it Breslow thickness, and other high-risk features, things like ulceration or its reproductive rate, its mitosis. This will help guide the stage of the cancer at diagnosis. The next step from there is to determine if excision alone is necessary. And many times it is for the very early cancers, like the in situ cancers that haven't started to invade or spread yet. However, if it starts to get a bit deeper or if it has its high-risk features, we might recommend something called a sentinel lymph node biopsy. A sentinel lymph node biopsy is the biopsy of the lymph node that if this cancer was going to spread, it would spread to first. And so we really don't care about all the lymph nodes, we just care about the one or two that matter. So in those patients whose tumors are a little thicker or have these high-risk features, typically we would do a wide local excision and we would check the lymph nodes in the surrounding lymph node basin. Regardless, whether it's an excision alone or excision with a sentinel node biopsy, these can typically be done as an outpatient setting, so you would expect to go home the same day.
What happens if melanoma has spread to the lymph nodes?
So if the lymph nodes are involved with cancer, this upgrades the tumor to stage 3. So we think of cancers as stage 1, 2, 3, and 4 across all cancers. Stage 4 in melanoma is cancer that has spread to other organs. Stage 3 is typically melanomas, and there are a few other features that have gone to lymph nodes. In times past, until just around the last 1 or 2 years, typically if this happened, we would do what's called a lymph node dissection. Most frequently, you hear about this in breast cancer patients, where we remove all the lymph nodes in a certain basin, such as the armpit. But in melanoma, more recently, we now know that this does not save lives. So instead, if cancer has gone to the lymph nodes, we start to think more and more about the use of additional therapies, things that target the melanoma and target our immune system as a way of reducing recurrence. We check the signature of the melanoma. We check things like what's called the BRAF status to see if it's sensitive to some of these drugs. And now more and more, we have drugs like PD-1 inhibitors that are shown to be highly effective at reducing recurrence of the melanoma. We can use these in stage 3 patients, we can use them in stage 4 patients, we can use them in isolation, we can use them as dual therapy. And so it's really important for us to understand the signature, the molecular signature of the melanoma, and to understand the patient's characteristics to figure out which is the best course of therapy.
Does surgery cure melanoma?
In rare cases, the initial melanoma we will do is inpatient. For instance, some patients come in and their melanomas are in a region that's hard to remove. We might engage our plastic surgery colleagues and we might do a reconstruction, for example. Rarely, for instance, when we do those on the scalp, we might admit the patient just for monitoring of the new reconstruction. More typically, we admit patients when they have this lymph node dissection. So for instance, there are still a subset of patients who might still meet criteria to have their lymph nodes removed, but this is becoming less frequent nowadays unless we know there's significant disease involved.
Are there any new treatments for melanoma?
Melanoma is changing more rapidly than most other cancers in the world. This is a great time for melanoma research for sure. And here at UMass, actually, we took part in one of the largest national trials open, which was really fortunate for us. And Dr. Ali, one of our medical oncologists, is actually an investigator on a number of national trials for melanoma for us, which has been great. The biggest kind of new kids on the block, so to say, are medications such as ipilimumab, the PD-1 inhibitors, and these BRAF inhibitors like venurafenib. And it's really based on the patient characteristics, the tumor characteristics, and like I said, this molecular signature of the cancers, which ones work best for a specific patient and tumor. These drugs have now been shown to be associated with a significant improvement in reducing the recurrence of the melanoma. In stage 4 disease, survivals are much higher than we've ever seen before. So this is the first time we've really seen drugs that work. In times past, all we had was interferon. And interferon was a terrible drug. It made you feel like you had the flu for a year. Now these drugs are much better tolerated. Patients typically can go to work, which is nice. It's always what they want to know. And their benefit, their outcome is real. It's not just numbers that aren't significant.